Great. Okay, I'm under strict instructions. Half of the instructions I don't even know yet, but will be communicated to me by other people. So um, this is a very important part of the afternoon. And I would like to thank the panel for joining us here today. You can read the biogs of the panelists in the programme, but I have start off by welcoming Denise Lawler, who's here under, I suppose, two hats, or previously with the as a board member was the National Nursing Midwife Board for Ireland, and currently working with HICWA. Marion Dwyer's GP from Start Doctors, Professor Jennifer Donnelly, who is the obstetrician and gynaecologist with the Rotunda and the Mater Hospital, Gerry from Túsla, the regional manager for Túsla, and Caoimhe Gleeson, who's the general manager with the Human Rights and Equality Unit of the HSE. So what I have been given a few questions to ask. I have thought of others as I have sat and watched today. And what I would like to do is going to do one question to each person and then open it to the floor. If I think of something, or I think that you might be thinking of something while we're listening, I might come in with a second. So we have 30 minutes. And I suppose what I wanted to start off, first of all, maybe Gerry, as you're sitting beside me, I'll start. What do you think the key actions you can take within your role, and what you bring back to Túsla to address the barriers that you've heard about today? Yeah. Push it up.
Thank you. Yeah, no, look, I've really enjoyed today, and delighted I came down all the way from Letterkenny to be here. And I've been blown away by, firstly the findings from the research, but a lot by the personal stories of people, as they describe their experience here today. One of the key things I'll bring away from this today is really, I suppose it's about viewing the world, in terms of services, in terms of how they enable and how they identify barriers and how they try to overcome barriers. And that sense of, checking our services in terms of equality and sensitivity towards disability. Because I think there's two ways of looking at it. When we meet parents with disabilities, I do think as an agency, we often take a very protectionist approach. Yeah. What is it that we need to do to keep children safe in this scenario? Yeah. The challenge from here today is, what do we do to enable people to actually overcome barriers, to actually, be able to parent their children to a good enough standard, not to an excellent standard, because none of us achieve that, or very few. So the other thing I take away, I have a national brief for the integration of services and service pathways. So if we have, no matter what service user comes to our door, we need clarity around the pathway to good services for those people based on the need that they present us with. And I was thinking of Grace's story earlier when, she was coming to maybe her prenatal care, and why aren't services picking up at a very early stage that extra support is needed here for this individual to actually parent their child well, rather than the shock of having to do everything once the baby is born and not be prepared at all. And then you're into panic. I remember my first baby arriving, and I was in panic just when I brought the child home, just by virtue of it being your first child, never mind having to manage a disability and care for the child as well. So what I'll take away from here today is really, we need much better services and much better integration with our services, both in the HSE and maybe other professions out there in the private and voluntary sectors, as an enabling entity to actually help parents care for their children successfully. And and less of an emphasis on the protection bit. I think that our journey in Ireland through social work, and remember, social work only really took off in Ireland, I would say, in the 70s and 80s. And we've had to respond to a history, you know, the history of abuse that has occurred with children in Ireland, and much of the emphasis of our legislation and everything else has been around protection. And that was needed at that time. But we need to move forward. We need to actually change that a bit now and become a much more enabling agency in terms of parenting. And one person mentioned parenting capacity assessments earlier. I'd like to say Túsla and Túsla are doing less and less of those. Yeah, and the reason we're doing less and less of them is because we've an approach to practice that is around signs of safety, that looks at the strengths of parents in terms of parenting their children in the first instance, not at the weaknesses, and building on those strengths. And my experience is when we're asked for a parenting capacity assessment at the moment, it's usually by the courts. Yeah.
Okay. Thanks, Gerry. And I just want maybe to go to Denise. There's been a lot of talk, and for all of you, you know, will have heard it of disability being identified as a deficit rather than, you know, a difference, or something indeed that many of people have talked today about, something that should be celebrated and recognised. And I'm just wondering, we've heard a lot about the barriers, and the research talks about barriers, and you have a lot of experience in terms of nursing and now in terms of regulation. And how can we get staff to work in a new way that we've all been talking about? And you know, what, from your own experience, what barriers have you experienced, and what measures you might have put in place that you comment on?
Thanks, and again, thank you to the organisers for the invite, and I've had a really enjoyable day. A couple of observations, perhaps. A couple of observations, perhaps, before I start. I would have been involved in a research study about 15, 16 years ago. And our findings, whereby we looked at the experiences of people with a disability accessing maternity services. And we looked at the experiences from women with a physical disability, a sensory disability, intellectual disability, and mental health. And the findings today are exactly the same as 16 years ago. I have just been transported back 16 years ago. And, you know, then what we classified the core issues being was around discrimination, institutional, within an ableist culture. And that still prevails today. We did share our findings, and when we share them, I think what we try to do is get the message out that, you know, this could change, and the big thing that needs to change was attitudes and interpersonal skills and communications with persons. We were successful probably for the first year, and then it just fell off again, as your own findings have identified here 16 years later. But I think what the project has done is it's shone a light on those again. And I think you've also gone further and developed toolkits. But what I would like to see going forward from a practice perspective, and I do think we have instruments there that certainly will help practitioners and clinicians in this domain, and I'll come to those in a moment. But I think the toolkits are very practical and can be implemented. But the issue will be around who implements it and the support to implement that. And that will require a multi-agency approach, and it's a system-wide approach that's required. But the instruments are there. If I put two hats on, professional regulation from the Nursing Midwifery Board of Ireland. We have our code of practice, we have our practice standards, and we have our scope of practice. And person-centred care, women-centred care is the cornerstone of those standards. And if I then put my other hat on from a service regulator point of view, which is HICWA, I'm involved in the regulation of healthcare services, so your acute services, your maternity services, and I have colleagues who are involved in a disability perspective. And we monitor, again, compliance with standards. Now, standards don't have a legal framework, but they are practice standards that have been mandated by the Minister of Health. So therefore, all health services and residential services are required to meet that standard. But in terms of those standards, we've recently, last year, changed our approach, and we've put people using the service at the centre of our approach now, and the voices of those people need to be heard. And when we inspect those services, the first people we talk with are the people that use those services. They frame where we then go from there on our inspections. And we also have person-centred care as an element of those standards. And they are based on human rights. And that's protection and promotion of privacy, dignity, autonomy, and non-discrimination. We use the FRIDA principles to guide us in our practice. So what I've taken from today is that change is very slow, but change needs to happen. And I think you're right, Gerry, in terms of we need to enable people, regardless of the level of ability or not. And it's not the level of ability or not that is impacting on whether people can do something or not. It's how other people perceive them to be able to do this or not. Motherhood is a challenge for any person. Certainly it was for me when I started off, and I've a pre-teen son at this stage. And the challenges that I would have done some work around transitions to motherhood for women with a disability. The challenge that I would have heard from women with a disability in relation to transitioning to motherhood is exactly the same challenges as I would have had, or any of my colleagues, or any of my friends would have had. But it was compounded by people's perceived ideas of whether or not a woman with a disability can or cannot be a mother, and can or cannot pay your parent. And that was enforced on those persons from a society which is driven by an ableist culture.
Okay. Thanks very much. Thank you, Denise. Marion, I wonder whether you might talk to us about something that you've learned today that you didn't know. Came in.
I suppose my main reaction to today is to feel confronted in a good way. One of my hats is I teach medical students, and I teach them consulting skills and communication skills. And I like to say to them, imagine what the world looks from the other person's chair. Because it's not what we believe as doctors that is the only thing that's important in the room. In fact, I try to teach that it's the less important thing in the room when it comes to decision making. Yes, we need to give information, we need to explain risks. But for example, when it comes to things like abortion healthcare, for me, the frame of reference that the person coming to consult the doctor has is what should be leading the discussion. But I've been confronted today and forced to think about my own practice, and am I just hearing so many, the research and the personal stories, am I setting the bar high enough for myself in my own practice in terms of applying that, apart from telling other people to do it? So that's been an impact. I mean, what I hope to take away is the toolkits, which I think are great because they're practical, they're clearly written. So I will be able to bring those back into the areas in the medical education world where I am. I suppose one observation I want to make is that my fear is that because of the pressures on the number of, in my world, doctors, but it's true, I think, of nursing as well, and in many other fields. My fear is at the moment we have, thankfully, more than 400 GPs who hold contracts in abortion care, for example. And they are by and large enthusiasts. And I think I can say that those who provide, once you get to them, will make an effort to facilitate people who come to them. And many of my colleagues will go above and beyond because they are enthusiasts. The good news is the younger doctors coming through the system and the medical students are very, very keen to provide reproductive health care. My fear is that because of the number of practitioners going down and the population going up, that we could be left with not enough providers, even in comparison to what we have at the moment. The final thing I would say is when you look at where providers are thin on the ground or where an area is well covered, because it's not just numbers, it's also geographical distribution, as you know. You find that there's a good number of GP practitioners in areas close to a participating hospital, because as GPs, we need to know we have that backup on the occasions when we need it. And I suppose I'm hoping that as more hospitals come on stream, that will help to increase the number of providers and therefore the longevity of the service. Because if we have people dropping out of providing this care, then we all have a real problem. I think we need to look at ways to address that. And thank you so much. I have a lot to reflect on.
Okay, thanks very much, Marion. Jennifer, could I ask you, what would you say to disabled people who are going to be accessing services that they should do or should expect as service receivers and recipients?
Well, I suppose one of the things that I've taken from being involved in this whole project, as well as I suppose my experience over the lifetime of working, is that ultimately, while it might be as an obstetrician my role to provide care and information, it's not really my role. It's not my role to tell people what to do, but to support them and to try and point them in the right direction, and also to be an advocate for their needs. But I need to know, I need to find a way of working out what that is so I can provide it appropriately. And I think that's what's been so fantastic about being involved in this project, because while you can see it through working, it's, having the research to back up the experience is so important. And when I'm working, one of my main roles really is to speak or to provide care for women who are pregnant with medical disorders or who have additional needs, and they've come to my service because there really isn't, it sometimes can be hidden within maternity services, and sometimes those services can be boundaried. So having the toolkits and being able to share them, implement them, can hopefully be helpful. I think what Maria said earlier on in her talk about abortion care is, if you're lucky enough to sit in front of a doctor who knows, that's really not good enough. That someone could be just lucky enough to be in the right place to have a doctor that's caring. And I think a lot of the personal stories that came through, that they felt that they met a person who might have been nice, they might have been kind, they might have had good intentions, but unless they have the tools and the education to help them, then there are still barriers there. And Nem mentioned it as well in terms of accessing abortion services, and really highlighted something that I see the other side of, is that people who have difficulty in accessing care, when they are finally able to get there, things are much more complex for them, and much more complex in order for them to resolve their situation, whatever that may be. So it gives me great hope to have this toolkit. And I think that just something that Louise had said just in the break, just before we started, was that, within healthcare. There's mainly just people that are doing their jobs, and their biases are that of society. So in order to have tools to educate people, to educate healthcare workers, to make practice better, I think is really important, and one of the things I hope will come out of this.
Okay, and Caoimhe, what I wondered, and I don't expect you to speak on behalf of all of the state, but how do you think the state and its agencies can involve disabled people more in their work, planning, delivering, monitoring services, or processes, given what we've learned from this research, and also given what Denise said about 16 years ago, and that this information isn't new?
Well, I'm not going to speak on behalf of the state. I work for the HSE, so I'll speak on behalf of the office that I work at, which is the National Office for Human Rights and Equality Policy. So before I do that, though, I want to say that those stories, all of your stories that you shared today, were just so profound. They were, I think the work that Eleanor has done and the team have done, and the previous project, The Voice, this room has such memory of such profound stories that I just want to really acknowledge that. I'm very moved by it, and I'm sure people that have, because we've got colleagues that are on Zoom as well that are tuning in, and I'm sure they're like myself. They're I suppose you just being in the room and hearing the story. There's nothing like it, just to really kind of sink in terms of how important it is for this forum to take place. So just to say that in the first instance. In terms of the question, the work of our office, our approach is that it's co-production, not faux production. That people need to be at the table. That any event that we have, anything that we design, anything, and particularly since COVID, in particular, that it's so important that we have lived experience. And today has just reaffirmed it. It is just, I don't see why you wouldn't do it, But we also have a role, and something that Eleanor said at the very beginning, that and I think it was a challenge to us, that we need to push for change in spaces where we hold power. We hold power. And I think we have a job in our office with our colleagues. We work, like the HSE is a massive organization that is all over the country. And I think one of the roles of our office is to kind of shine the light, hold the organization to account, to say, well, how did you get that information? How did you design that? Who was involved in that? How do you know that that's going to work? I mean, one of the things that really struck me today is that whole thing about a trauma-informed perspective. That's not discussed in our organization. I know it's somewhat in Túsla, but it's new. But, with all of those stories, they're trauma-informed stories. So, I think that's something that we really need to step up. There's a number of pieces of work, and the same as Denise, I also was involved in research 16 years ago, in fact longer than that, 22 years ago, and I suppose what I see is things haven't changed, but what's different now is you are telling the stories. They're not being interpreted by other people, and that, I think, is incredibly important, but it's a game changer, I think, in terms of the dynamic, and I think we have to absolutely make that a core part of what we do. And I think as well, there's a lot of talk in the HSE now about patient engagement, person engagement. That can't be generic. It has to be. I think one of the things about today is that there's so it's disabled stories, but within disabled stories is such level of diversity that we just don't even see. So I think, we have a job as well just to be able to see that. So anyway, thank you, and sincerely thank you to everybody. And it's great to see people that I haven't seen for many years. So looking forward to doing, one last thing to say as well, we developed guidelines on universal access in 2015, and we're reviewing them. But even from today, and my colleague Jacqueline is here, we were just saying, we need to completely rethink about how we're going to do this, so and thank you for kind of enabling that as well. So thanks.
Okay, I'm going to open up to the floor, if that's okay. 10 minutes left. 10 minutes for questions. That's not bad. Okay, so going to take a few questions together. Okay, Carol.
This isn't a question quite so much as a comment. Again, I just want to echo what so many other people have said about how very rich and rewarding this conference has been, and I've been very privileged to be part of this this particular project. My focus focus of my work is in the courts, child protection in the courts, and it has struck me today that one of the entities, one of the institutions that does need to be aware of the work that is going on here is, of course, the courts and the judiciary. Now, there is a constitutional issue here because the judiciary is independent, but we do have changes taking place with a new family court bill. The Department of Justice has got a whole programme of family justice reform, and there is a new judicial council which has a remit for the training of judges, which is now going to happen on a much more organised, formalised way under the direction of Ms. Justice Mary Rose Gerry, who, she, as a High Court judge, she is there, and she is there with another colleague, another High Court judge, to ensure that it is judge-led, which is best practice internationally, but I know that they are very open also to taking information and research and learning from wherever would be relevant and appropriate. So I just think that that is something that the project, Eleanor, Jenny and everybody else look at ways of sharing the work that you've done more broadly.
And if I put my NAS hat on for 30 seconds, that's really important. And I'm on the Department of Justice's advisory group about the new family law reform, and I think that this research, it's really important that that's fed in to that process. And also I work with the court service on their reform measures. We haven't quite got to the judges yet, but we might get there. But I think that's important, and for all of the other agencies as well who are involved in those processes should learn about this work, because just because they're Bernardo's or Women's Aid or whatever organisation they represent all women or all parents, so like for those of us coming in with our disability hats on, we need allies, and we need, the other groups that are involved in campaigning on these processes, to be fully informed. Okay, next.
The research is just powerful. Yeah, can you hear me now? So the research team has, I just want to mention the research team. It's absolutely powerful what you've done, and having the time to take on board all that we've said and all of our stories, and then compile the report that's going to make the changes. And like you said, we can give our lived experiences and I can talk about my experiences from 20 years ago, but I can also talk about my experiences now. What I want is to see the change. I could keep talking about our experiences, and we keep, mentioning them and having these discussions, but what we need is to push for change. And it's, the NUIG, the University of Galway, change of name, that has, it's been fantastic in recording all of our stories and, from people with disabilities. And to capture things and barriers that we face every single day, and to show that we can enjoy, our lives, and most of us have, 20, 40 years left in us, so we want to enjoy that as well. So maybe, people who are involved in the system, we just need to keep in mind that change has to happen now. It has to be now.
Anyone else?
Very much. I just want to ask a reflective question, probably if it can be answered from the discussion. I really picked it up, appreciation that a little has been changed since the advocacy or issues on disability are concerned. So my question is, who has been left behind? Or I would also put it in the same way to say, what has to be changed? Probably something needs to be changed. Thank you.
Who wants to take that?
I don't know if I can answer it, but I'll make an attempt. I think, as I said previously, we have instruments there. We have standards for professions, and we have standards for healthcare services. Core to those standards are person-centered approach and respecting people, and that's framed within a human rights-based framework. So I think they will help. I also think the practical toolkits that have been have evolved and have been developed out of this program will help from a practice perspective. But I think what you need is commitment, motivation, system-wide, I suppose, commitment to change here, and multi-agency approach in terms of this. This is not just healthcare, it's everything else that needs to be looked at here, just as you rightfully said, from a legislative point of view. So one person or one agency cannot do this. So it's bigger than, I think, the individual. It's greater. It needs to be, you know, system-wide and multi-agency. And that needs, you know, policy as well. So you've got your policy makers need to be at the table also in terms of this. So there's, you know, multiple inputs that are required, you know, and it's, I suppose, a commitment from multiple agencies and multiple persons that will drive this forward. As I said, 16 years ago, the findings are exactly the same, and very little, if anything, has changed. And I think you're so right. It's demanding implementation and change, and that's what should be the drive going forward from today.
Gerry wants to add to that.
Yeah, no, and I agree with that. And but I think going back to maybe as well what Caoimhe said about, you know, it's something about, you know, nothing for you without you type approach, where basically the people in this room need to be shaping policy and need to be pushing and driving services, and certainly in my experience, you know, within Túsla, the engagement with children and families has led to them shaping our services more and more. And it's not the policymakers at the top and the people at the top or the legislators all the time that are actually doing that. So I think, you know, if there was one thing that needs to come out of today, I think there actually needs to be some sort of multidisciplinary group sitting down with a group of adults with disabilities to talk about pathways to good services, or what looks like good, or what is good, and help us shape that and help us move it forward.
Can I make a comment? Yeah. And I think, you know, there is a sense in some ways that maybe things haven't changed in 16 years, but I think things have. I think obviously there's the negative side and the positive side of that. And I think a lot has changed, as many people have made reference to, and there's an awful lot of hope, I think, that can come out of this work and for the future. And I think people's attitudes have certainly, I hope, changed in 16 years and will continue to do so, and will only change when, you know, this kind of work is incorporated into conversations on a grassroots level, and then that will feed up to, you know, and across, and hopefully make networks rather than pyramids. And I think that certainly, I hope, has changed over the last 16 years.
I know that Byrne and Orla aren't here, but I was very struck by what they said this morning about the first thing that was said to them when they got married is that they couldn't have children. You know, and when is that going to change? That conversation going to change with people? You're talking about the strengths model, Gerry. You know, that disability should not be automatically identified as deficit, or something that needs fixing. And if it can't be fixed, then the services get withdrawn, which is, I think, a lot of people's experiences where, you know, engaging with Túsla and then the disability doesn't go away. And that's the other thing. People think that when you can work in certain parenting supports to improve things and improve strengths, but there are still some elements of disability that will remain and need to be supported. I think our experience of disability services is that they don't want to get involved in parenting issues. Túsla don't want to get involved in disability issues. in lots of ways. So there's definitely conversations and change that need to be had there. Have we got any other questions? No, I don't know how to find them. So, and I have 0 minutes left, sorry. So I will, well, I can't see them, so, oh, can you read them out? Okay, okay. Okay.
Okay, so the first one is a comment from Caoimhe Blair. Superb conference for our expertise, and do not reduce, remove our support system. I am woman, hear me roar. And the range of global realities says it all every time. The researched are now the researchers. We are the experts in this area as disabled living our lives. Stop asking us for our thoughts. Pay. I don't quite get that last bit. So that was one. And then the other one is comment for Professor Donnelly. Having received a mental health diagnosis, it was based on historical family background and not as an individual, and ignore the difference in that my family members were male and I am female, with the complex and complicated medical difficulties of PCOS, endometriosis, rare blood group, chronic kidney disease, amongst other issues, diabetes, or various sort of unpronounceable types of diabetes, hypothyroidism, and it has been very difficult to get a specialist, i.e. a specialist psychiatrist trained in hormonal imbalances associated with PCOS when the estrogen declines and leads to mood swings, which are symptomatically akin to bipolar affective disorder with endometriosis. When the estrogen is deliberately declined, its known treatments lead to mood swings and symptomatically akin to bipolar affective disorder. HRT is designed to assist with the mood swings of declined estrogen, i.e. as in endometriosis. I need a medical degree.
I don't think Jennifer's going to be able to address that in terms of individual cases, but I do think there's probably an issue there in terms of how do people access services that actually understand the needs and can give the time, and that we definitely need to see a provision of services and working on developing the interest and expertise of services so that they can meet the needs of people with complex medical histories, definitely, yeah. Before I hand the mic over, I just want to pay tribute to the research team for their care and their expertise in this project. And I want to thank the panel. You know, I just think that today has been excellent. The whole project, there's so much work to be done. And an awful lot now of good stuff in terms of the toolkit and the research and the commitment to bring this forward and create real change to, you know, enhance people's lives, support people's human rights, and support their experiences of using health and social care services and accessing reproductive justice. Thanks very much. Thank you. Now,
okay. Gosh, if you told me an hour ago we were going to finish this event on time, I would not have believed it. So, Suzy, that's due to your expert chairing of that panel now, and our panelists for being very succinct in their answers. So thank you so much for that. Okay, so I have the difficult task of trying to bring all the threads together from throughout the day and closing the event and thinking about the next step. So I think a constant theme has been not enough time, but I hope that the little, very short things you've heard today would spark the appetite for more. So we've heard the need for more research, but not just more of the same, hearing about how research has identified these things already, and yet no actions have been taken. So it's not just research for research's sake, but more action and more engagement. And hopefully, you know, the ideas we've got from our panelists, particularly in the last session, show that there are ways, there are initiatives that are happening. So it's about how we can get disabled people who have that expertise into those spaces that you've all identified now. And I do charge you to try to take that forward, as well as myself and all of us that are working in this space. I really hope that everyone who's coming here today with an idea, with a knowledge that like things aren't going right in your practice or in some work you're involved in, but you don't know where to start to change them because it seems so overwhelming, that you've got some answers and some ideas and made the connections. So, you know, if you've heard someone today that you thought, yeah, they get it, they're on the right track, do make the connection with them. I'm so pleased that we've been able to have this gathering both in person and online. So, you know, use the opportunity, use the mailing list from today, and don't forget about it. Really do find ways to involve people in those work, whether it's the reform of the family law system, whether it's updating of policies within services, or ways in which people can get involved in training and direct delivery, or audits, including access audits of different services and spaces. So I did say at the start of the day that I was going to really challenge you to think of one thing, at least one thing you can do as an individual, and one thing you can do at a systemic level, because we've heard from our panelists the real need to take systemic action. And whether, you know, we work in a professional context, and we can think about the systems we work in, for me in the university, or for others in medical practice or in hospital settings, thinking about what can you do at that system level that could help to change things. And for activists, and we're very blessed to have so many activists involved today, to think about in the collective, and you already are, about what you are doing and what other spaces you need to be knocking on the doors of, and making sure other social movements recognise, as we heard from many of our speakers today, the urgency with which disability justice needs to be achieved in conjunction with reproductive justice. So whether you write it on a napkin from the coffee, or the programme in a corner of the programme, or on your phone now or on the way home, do commit to an action. I'm not going to ask you all on the way out, but I'm very tempted. I'll resist. So in terms of the next step, so this is the culmination of 4 years of work, but it's not over just today. So we will be looking for opportunities to disseminate the findings and the toolkit. So please tell us if you know of an event, a conference, networking opportunity where we could come, or we could suggest people who could go and talk about what needs to change. Then please keep in touch with us about that. I suppose of the project team, I'm the only person who is permanent in the university, so direct it to me and remind me, because my email inbox is a bit of a dustbin fire. So, but do remind me if there are things that you think, if it has reproductive justice in it, it's got a better chance of being read than some of the other stuff in there. We're very lucky that we have a contract with Cambridge University Press for a book that we're publishing from this project. So keep an eye out for that. And like I mentioned earlier, that we're very grateful to Mary Duffy for providing the artwork that's going to grace the cover of that book. It's really incredible. She's also provided us with a print that we're going to display here, so we never forget that we did this work together. I have to thank a number of people, because this project, as is everything I do, is a collective effort. And so it wouldn't be possible without the involvement of so many people here today, and not here today, but very much part of the process. First of all, obviously, welcome Trust for funding the research and taking a chance on this idea, and those who helped me come up with it on a whiteboard in my office many years ago, where I was trying to draw very bad Venn diagrams of all the things that I needed to try to put in this project. The project team, who've been absolutely incredible from the very beginning of this project. So Anya, Emma, Jenny and Maria, it's been an absolute privilege to work with every single one of you. And I think we will always keep connected to this kind of research and this kind of work, and our other work as time goes on as well. So it's been really incredible to collaborate with all of you, and all of our backroom team and staff and volunteers who have made today such a success. Joe, Sharon, Mary, Cleena, Emily, Carrie and Paula for doing the excellent timekeeping and keeping us all moving forward. It's been really great to have all of the support from everyone here. Everything we do in the CDLP is kind of like a family, so it's great to have such support from each other when we do events like this, especially since we're a little bit rusty on in-person events after the few years that we've had. Also, our incredible stakeholder group and project ambassadors, Suzy Byrne, Selena Bonney, Jennifer Donnelly, Carol Coulter, Theresia Degener, Roisin Dermody, Elaine Grehan, Teresa Lynch, Grace Agusanya, Ellen Murray and Kathy McGrath. Really appreciate all the thought and effort that you put in to guide our work over the 4 years of the project. We wouldn't have been able to do this without you. The services that have made today accessible, especially our interpreters, Lisa, Bernadette, Alison, Anna, the captioner, Karen and Cormac and team for providing all of the tech options so everyone could know everything that was going on. We really appreciate all of your help. I want to close with a reflection on Access is Love, which is a slogan developed by Alice Wong, Sandy Ho and Mia Mingus. And it very much is connected to that idea that Mia Mingus wrote about in a keynote address she gave, where she said that disability justice is another word for love. And that might sound a bit wishy-washy and like Eleanor is leaving the day with peace and love and like flowers, but it's actually really critical to what we're doing, because if we don't think about that, we're not actually going to move things. Like, so many people who shared their stories in this project and today, when disabled people show up and they're told, oh, we've never encountered someone like you, we've never had a request for that before, why do we need to do this way? What they're being told is, we've just never thought about you. We designed all of this and we never thought that someone like you might exist and show up someday. And that's not good enough, because if we know disabled people and we love disabled people in our lives, then we have to keep showing up for each other and demanding better. And we only do that if we really love people and we care about them. So I think that is important to place that at the centre of our commitment. Mia Mingus writes about that concept of liberatory access. So she says, I mean, access that is more than simply having a ramp or being sent free or providing captions. Access for the sake of access or inclusion is not necessarily liberatory, but access done in the service of love, justice, connection and community is liberatory and has the power to transform. I want us to think beyond just knowing the right things to say and be able to truly engage. I want us to not only make sure things are accessible, but also work to transform the conditions that created that inaccessibility in the first place, to not only meet the immediate needs of access, whether that is access to spaces or access to education and resources or access to dignity and agency, but also work to make sure that the inaccessibility doesn't happen again. So if I could leave us with one idea, it's definitely that work on repairing the harm by making sure it's not repeated. And that's a key call that I think disabled people deserve to happen in the systems that govern reproductive justice, not just in Ireland, but globally as well. So thank you all today for your attention, for your engagement, and do keep connected with us and share what you're working on and ways in which we can continue to contribute to make things better, because everyone deserves a better experience in the reproductive system. Thank you.